The last topic of the discussion is disclosure of medical errors. And I think this is one topic which is always kind of left unaddressed because we are clueless on how do you really go about. And we normally think, let's cross the bridge when it comes. But that's not true. For a topic like this, I think we really need to prepare ourselves thoroughly. So my first question to all of you is, in case you were in a flight which had a near miss crash, and some passengers, including you and your family members, were slightly injured when, in the flight. So what would you like to know, from whom and when? Should I repeat the question? So if you were in a flight which was in a near miss crash, and some passengers, including you and your family members, were slightly injured because of the jerks and because of the turbulence. So what would you like to know, from whom and when?
I would want to know from the pilot itself as to what was the reason. Of course, the first point of contact would be the air hostesses, because we won't have access to the pilots. So through them, I would want to know what is the reason why this has happened and why sufficient warning wasn't given, in case, they're obviously aware when there's going to be a turbulence or any problem. Because people are hurt, that is why. If it was
absolutely.
And people are hurt, so definitely I would want to understand how is it and why weren't we forewarned, and what is the kind of precautions were supposed to be taken. So all of this I would want to know through the air hostesses, from the pilots, and after obviously the thing has been settled down a little bit, and if it has necessitated that the plane has to land at the nearest airport or something, obviously that is that is when I would want to have proper answers, because I wouldn't want the pilot to answer me when he's supposed to be flying the craft, or she's supposed to be flying the craft.
So that means as early as possible, as soon as the things have settled, I would like to know what
yes.
So
after things have settled down, that.
So Dr. Tanu, if you were denied, if you are not given enough explanation, how would you feel?
I would be very angry and frustrated, and I will feel shortchanged, so to speak, that I haven't been given.
And in case if you could clearly see that there was something that happened, but they're just trying to cover up and say it was turbulence or it was bad weather or something, will you be satisfied with that explanation?
No, definitely not.
Absolutely.
Then I would definitely go the whole hog.
Exactly.
And threaten legal action.
Absolutely. So let me narrate a couple of real case studies that happened. For example, a patient Rakesh Tyagi. I've changed the name. Of course, if you Google search, you'll find this case. So this patient had a car accident, had head injury. He was brought to one of the premier hospitals of Delhi, NCR, and he was operated on his leg for the fracture that he did not have. When the family got to know, they were very furious and they wanted to know what exactly happened. In another case, again in a very premier institute, a physiotherapist around 50, 51 years of age. So she, had cardiac arrest because her diagnosis got delayed, where the residents did not notice the changes in her ECG and also did not take timely action on the high BP. And she kind of passed within few hours. Again, the family was very furious. They also went to court, and we had medical litigation against them. In another case, again a very premier hospital of Delhi, a 30 years old lady, she had come to a hospital for minor abdominal pain, but again she was mistaken for another patient who had come for dialysis. So the resident actually made a, arteriovitreal shunt for dialysis without confirming if it was really the same patient or somebody else. Now imagine these cases. These have come to light because people have spoken, patients have spoken, somebody has noticed, somebody has brought to the knowledge of. But we all know a lot of such medical errors happen in patient care. So wrong side surgery, wrong medication, wrong patient, wrong treatment, wrong side amputation. We have seen all these kind of errors happen day in, day out in front of our eyes. So I was reading this book, Checklist Manifesto by Atul Gawande. So he said one of the engineering department, recorded the number of activities you need to do in ICU for a patient. And can you imagine, they noticed 178 actions to be taken by the healthcare, team in 24 hours for a patient. And every patient is likely to experience around 2% of 1 or 2% of errors. So around 2 to 4 errors in a day are kind of already recorded. A lot of them get unreported, unnoticed. But a lot of time when the harm is visible, you cannot cover up. And that becomes really very challenging for anybody to, actually talk about it. So let's quickly do a small role play. So this time I want, who would be the doctor on duty? Anuradha, will you be? It's okay.
Okay,
It's okay. See, I don't expect anybody to be really, seasoned at it. But the idea is we want to get into the role and see how it feels. So for example, if it was this case of patient Rakesh Tyagi, who had car accident, had head injury, and he was taken to the OT and operated on his leg for the fracture that he had not received. After the patient comes out of the OT, you can see the plaster cast and everything, and you can see, and the family says he had nothing on his legs. His legs were perfect. And now you need to explain this to the family. So we don't need the patient, but I want two of you, somebody who has not played the role of patient or family or doctor. I want them to participate. Any two people who would be the family members. Any two. Will you be? And Chandana, will you be? Okay. So imagine that both of you are sisters to the patient. And Anuradha is the doctor on duty. And she's going to call you to explain what has happened. So imagine if any one of our family member have been done wrong, how would you feel? How would you behave? How would you react? And then how exactly you will be actually, talking to the doctor who has done this error.
Can you please repeat what exactly wrong happened with the patient?
Sure. So there was a patient, who had who met with a car accident, and he had a couple of clean lacerated wounds that needed to be stitched on the arm and at different places. But he was mistaken for another patient who had fracture and who needed, surgery for the fracture. So he was mistaken for that patient and he was operated upon. I'm sure there was no fracture, so they couldn't have done anything, but they opened the leg, and then it's visible that the patient has been dressed upon the leg. So once the patient comes out, the family is really surprised because they knew that there was no injury on the legs. legs are okay, and it's only the lacerated wounds on the arm that needed suturing. And now they have brought to your knowledge, and you already know, because you know this patient did not require this surgery. And now you are expected to explain to them, because they are educated, so they clearly know that something wrong has gone in. So since you are the surgeon who has done it, and now you need to explain to the family, and Amreen and Chandana are patient's sisters. So just let it be not more than 5 minutes of a role play. And Amreen and Chandana, you be like how a family would react if something wrong has been done to your patient. I mean, will you say, okay, it's all right, whatever has happened, I'm okay? Usually we are very annoyed. I'm sure, Amreen, you have seen a lot of patients where without any reason also they get angry and annoyed. So you can behave the way you like, I'm sure, Anuradha. So Anuradha, it's not about evaluating your skills at doing it, because I know you are not into clinical practice. But at the same time, I think it will give us some idea, how does it feel to be there? Okay. So we'll all have our videos off, and you have 5 minutes time. And anytime you feel, Anuradha, that I'm overwhelmed and you can have your video. I mean, you can say, okay, time out.
I'm actually in a difficult position because I've done a wrong surgery. So, no, so in this case study, I've done a wrong surgery. So I'm feeling very bad for the patient. But then let me handle it.
Exactly.
So, Amreen ji or Chandana ji, your brother Rakesh ji came to us last night, and he met with a major accident. And I want to explain to you the situation. It was a major accident, and there were wounds.
That all we know very well. That all we know very well. You just tell us how did plaster what all you did, how you got the plaster. Because as far as we know, there was no injury on the leg. So how did you operate it? Why?
So, Amreen ji, you are absolutely right. And
so,
you notice.
Rather, 1 second. I'm sorry. I should have given this instruction in the beginning. I'm sorry. So all others, please observe what Dr. Anuradha does well and start writing in the chat box. Please don't click the message. After she has finished and after I ask you to share your, observation, then press the chat button. But you can keep noting what all she does well, so that we can actually tell her that these were the things they were really done well. I'm sorry, I should have given this instruction, much earlier. Thank you.
So Amreen ji, you are absolutely right. The injuries were there on the leg, but then there was no fracture. There were lacerations on the hands, which required suturing. But then our junior residents were there on the night duty yesterday, and there was another patient who met with a major accident. So I'm really sorry to inform you, and I should be very transparent in informing you. The surgery was required for the other patient.
How can you say sorry for such a major mistake, ma'am? It's a life of a person. You're already a doctor. You know it very well. So you know what a patient is for you and for a family.
Yes, I take this whole responsibility, Amreen ji, on behalf of the JR who has done it. But let me assure you, the surgery was done, but no grave situation arises of that surgery. Your brother is completely fine. Although I agree that the surgery was
not be able to walk, ma'am, because of the plaster and other things, and you are saying that it's not a big deal.
Post-surgery effects will be there, right? He is facing it already. How can you say just a sorry to us?
We are there to take care, Channa ji. It's my duty to inform you with complete transparency what exactly happened. It happened wrong. I agree to it. And we are there to support and take care of your brother in every which way we can. And
trust you even that you are going to take care of him, in a proper way. We trusted you, and that trust has been broken. And how can we trust again? I mean, ऐसे कैसे कर सकते हैं आप लोग?
I completely
and
agree.
Do you
Channa
understand
ji,
that he will be bedridden for at least 2 weeks or 3 weeks till he is having plaster and he's having family to look after that? And what about his job and other things he's earning? How he's going to manage that? You will take care
Exactly.
of the wounds, we understand.
I completely
But what
agree with
about the job?
what both of you are saying, but it's my duty to inform you also what exactly happened and what exactly was done. And we are taking a strict note of what wrong was done. And to the JR also, we are taking a disciplinary action. But then for your brother, since this has been done, we are there to take care of everything. And let me tell you also, the surgery was not a major one. It was done while it was not required, but then it wasn't a major one, and there will be no major repercussions to that. Yes, I agree, there are post-surgical things which your brother will undergo, but then we are there to take care of that entirely. So please be rest assured, there'll be no major side effect that he will be suffering from. And we will completely document this situation on papers, and we take the complete responsibility of the entire.
Are you also going to take the
We are not
financial
going to charge for
responsibility?
that also.
So yes, we are
Reduce
taking
that
care of.
from your bill because it was your mistake.
We are talking to the authorities, and I'm in touch with the finance department as well. Whatever most we can done, we will do for it, because we are taking the ownership of the complete situation. So be assured of very righteous action in this direction.
Okay, ma'am, you do whatever you want to, but nothing should happen to our brother. You just listen it.
You can be rest assured, and if you have any queries, you can note down my personal number, and you can meet me also personally. My OPD is there every Wednesday in the medicine department. You can meet me personally to take the updates of your brother. I'll be there to support you and answer any of the queries.
Okay, madam.
Any further queries, anything, and I again assure you of a healthy and smooth recovery for your brother. Please don't
We
be
also want to
apprehensive.
meet the player who has done this particular mistake. We really want to
Yes,
see
ma'am.
him.
What kind of doctor he is going to be? Was he
Channa ji, I
sleeping
know.
while doing the work?
I completely understand that both of you, are it's your brother and you would want to meet, but then we have taken on our behalf a disciplinary action, and to now avoid the undue embarrassment, I would request you to please speak to us directly for any issue, and we assure you that we will handle it in our best way we can.
Okay.
So whatever has happened. Meeting the JR, I think, would not, help you in any which way.
So rather, you can finally calm them down.
I was feeling so bad about it.
I was actually feeling like, saying something more, but then again, it was not coming.
I know, because Anuradha was very cordial in her.
Yes, actually, yeah.
I agree. So now I want to ask, first of all, Anuradha, how did it feel to be there? I think that's most important.
Ma'am, it's a very difficult situation in the profession that we are. We can't afford to create mistakes. And even if it is done, it is very hard to admit it. It's hard to admit it. And it takes a very strong heart to admit it and then face all the questions and answer them, because in the heart of your heart, you know that wrong has been done, and it is a time consuming procedure for the healing and everything. So I think what lesson I got was, whenever something wrong has been done, somebody strong from the team should represent the situation. Like they ask very valid question, and it always happens that we want to meet that JR, although that will not help in any way. But then these are the situation when these violences and incidences, adverse ones, they happen.
Yeah.
Because at that point, patient would not understand that this will not help, but they would want to, obviously, if I am in their position. So somebody having that strong personality who can tell them, and at the same time reassure the patient, should be representing this situation, and that is what I felt.
Absolutely. So that means it's not easy, and there are a lot of ifs and buts, and also patient would have a lot of expectations, or their family would have a lot of expectation that don't charge me, or our bill should be waived off, and even whatever next has to be done should be done free of cost. And those concerns only person who has the authority can address. So what do you think you did well, Anuradha?
Ma'am, I could answer all their questions. And also to their question, when they asked to, meet the JR, I was, taken aback with that question. And I was thinking for a minute that what should I answer? But then I think that I handle it well, that by saying that whatever has happened, and to avoid undue embarrassment, we can't do anything. So we should not meet. And I'm there to support you. I took the whole responsibility.
I think that was really nice that you did not, agree to their request to meet the GR, because then it could have actually aggravated the situation. And you said, it's best if you deal with me and talk to me. Wonderful. So as a family, Amreen, you and Chandana, how did you feel to be there?
Ma'am, believe me, it's not that easy in government sector. Once you do even a small mistake, pure family wale, along with the relatives and other political people, they just come to the hospital and they call all the editors to write into the newspaper, and next day there'll be a big headline, another issue. All those things are there. It's not that easy as it seems to.
I completely agree with you, and that's the reality. Actually, that's the reality. Therefore, most of the cases go out of hand when they are not managed well in the beginning, and then it normally goes into the news and also social media and all other things.
And you are the only responsible. You have to manage all these things, because your seniors also, that CMHO and other people, they also go at the back of stage and they don't protect you that much. They just say ki it's your fault, you have to manage, we can't do anything. So it is.
Imagine what we are getting to hear from Amreen, that juniors are the one who face the brunt of situation, and that's why they are the one who are also experiencing a lot of violence against them. Absolutely, I agree with you. So if I may ask,
playing role, that's why our behavior also not that very aggressive,
Not
while
aggressive,
we know that in the actual situation I would have been very aggressive also.
I think that's the limitation of role play. That's one of the limitation of role plays, where you cannot actually in the real sense you can play your role, because it's just an artificial situation. So people will never come out with their genuine behavior. And also here, since it has not actually affected you, so there is no genuine emotions also. Plus in a group, you can't be bad to each other. You need to be nice. So therefore you will not misbehave with each other. Yeah, Anuradha, you want to say something?
Ma'am, keeping these things in mind, I have observed one thing, that hospitals and nursing home, bigger ones, they have started employing PR managers and communication managers. If these things happen, they would not let the doctor face directly the patient's family. The PR manager or a communication person would talk to them first, reassure them, and then this is the first step. And I see that this is important also.
But in case if something wrong has gone in, whom would you like to explain? The PR or the doctor who was the treating person? Anybody else who would like to answer this? Dr. Kunal, what do you say?
The treating doctor.
The treating.
Yes, the treating doctor.
Actually, I feel that if in such a situation, patient has to talk to the PR person, that would be even more annoying. Because that will come across as trying to protect the doctor, because the anger is directed towards the doctor. So they would want to talk to the doctor. And just as an aside, like I would, this is a true case, right? I would be interested to know that how did they operate? Like once you cut the skin, that bone is intact. So how do you operate on that?
Exactly. They didn't operate after that. They did not operate, but they had already made an opening. Based on either it was the wrong X-ray attached to this patient's file, or somebody did not check, like we normally follow the surgical safety checklist, identify the patient, identify the case file. So there must have been some mismanagement. And in one of the hospitals, I think that came into news actually. Instead of operating on the left eye, the patient was operated on the right. So not eye, sorry, leg. That came in news. I think it was one of the very big hospitals of Delhi, corporate hospital. And that shows that even, one small error at one point. And we have talked about that. We haven't talked about, but I'm sure people who are in quality, they know about the Swiss cheese model. When everybody fails to do a duty, then error happens. If everybody fails to do the duty, the nurse who sent, the doctor who operated, the nurse in the OT, the technician who, or anesthesiologist who gave anesthesia did not verify. That means everybody has gone wrong. Then such error.
Because even if one person identifies correctly, then the error won't happen.
It could have been correct. Absolutely. So that's what I'm saying. That although in role play you don't get to actually experience the same emotions, but I think Anuradha must have felt something similar to it, because she knew I'm being watched, and then I also have to see how best I can deal with this adversity. So it must have been very challenging. So I would like to ask the group to write their comments in the chat box, or rather click that button of enter, so that you can give Anuradha feedback what she did well. A lot of things, Anuradha, you did well. And okay, clear in communication, taking responsibility, providing support, taking the mistakes seriously, promising actions, promising documentation, promising the regular update, and not exposing the juniors. I think that was really done well. Absolutely. I think I agree with Dr. Kunal. Then she admitted the error without excuses. I think that's very, very important. I think if you are trying to cover up and say, oh, sometimes we are very busy, sometimes we have a lot of workload, then they don't like it. They think that I am not important, all other things are important for you. So giving such excuses, see, sometimes it happens that we kind of get confused, and then they will not pardon you. They will not accept. So Amreen feels that Anuradha was very calm and polite, and throughout the whole conversation, which helped to manage the situation very well. Yes, that's very, very important. So if she had raised her voice, she would have given you a chance to raise your voice. But because she did not raise her voice, so even if you were aggressive otherwise, or you have seen so much of aggression, or you wanted to be aggressive, I think you could not show aggression to her, because she was not giving you that chance. So automatically, as I discussed in the previous classes also, the other person is behaving nice, you suddenly start copying that behavior. And we all mirror, unknowingly we mirror. What we see is what we start showing. So if the other person is not behaving in a wrong manner, then you cannot go wrong. You are likely to imbibe that. Okay, so aggression fuels aggression. Absolutely, I agree with you. So she has taken ownership of her mistake, clearly communicating, composed, trying to make amends. Very good. Yeah, she was trying to offer the, whatever she can do, she will do best. So cordial, patient, nodding, took responsibility, explaining no harm. So this one point I want to ask you, when you say no harm, don't worry, nothing has happened, nothing serious has happened. So how do you think the family is likely to take? Are they okay with this explanation?
No.
Usually not.
Usually not. I think we have to be careful when we say, don't worry, nothing serious has happened. So for them, being operated, even for having a cut and then getting resutured is harm. Like the family member said, no, he will have to be on bed for 10 days till the wound heals up. So that cannot be, that should never be the reason to tell them that don't feel bad. Maybe if I have to say this, we can say, fortunately, thankfully, I mean, no serious harm has happened to him. I'm really, really thankful to God. So when you say this, you are saying that I understand the gravity of the situation, but I'm really thankful to Almighty, and I'm happy that at least patient is safe. We are safe. So again, when you say this, it has to be very well articulated. Then also you apologized number of times and you took responsibility. And you also said that we have taken a strict note of it and we're going to take an action on the GR. So again, I want to ask you, of course, as you said that, no, I will not call JR to you to confront him. That was a very well taken care of. So when you say action will be taken against JR, how will that be taken as by the family? Dr. Kunal, do you use this statement when you deal with something similar like this?
No, ma'am, because generally actions or any particular action against any grievance is not a single person's responsibility or task. So maybe a thorough investigation and a report, and then a committee decides whether what sort of action needs to be taken. So promising an action rather than sharing that we would promise an action, we could share that we could promise what and why something has gone wrong, rather than the person.
Or if I say, I think it's an error by a team, not one person. I think all of us have gone wrong in it. And we all need to learn from this mistake and make sure that something like this never repeats. So I'm definitely going to get into the root cause and see where we failed. And we will try to make sure that next time, we don't make that mistake. So whenever you will use the word we, that will also showcase that there is no one person behind the error. Because when you say one person, suppose if that JR did not have good rapport with the family, they were already annoyed and agree with his behavior, that animosity is going to multiply. And they can become, revengeful. Oh, he was never well behaved. He always was very rude to us. Every time I went to him, he was bound to make mistake. He's a careless doctor. He doesn't come on the first call. You have to actually go and tell him 10 times to come and see the patient. See how they start, building a story around it. So I think we have to be careful when we say it's one person who is responsible. And then, of course, expenditure part. So normally this is a very regular, question the family will have. Who will bear the cost? And what exactly happens in the hospitals? Honest. What do you say, Dr. Kunal?
Free treatment till the stay of the patient, and maybe at times for a longer duration, maybe after discharge as well, or say upcoming follow-ups and everything.
Wonderful. But in a lot of hospitals, they would ask the patient to bear the expenditure. Imagine if an error has been done, error or some complication has happened. Complication, still you can say that this is a documented complication and this is part of a treatment. So we cannot, completely do away with the expenditure. But error means they will always expect you to, bear the cost or share the burden. And expecting the family to share the burden is absolutely, wrong. But a lot of hospitals ask the patient and the family to bear the cost. So that's again a question. So in the end, you gave your number to them, and then you said that whenever you want to ask something, you can get in touch with me. That, I think, was a very reassuring thing for the family, because they knew that, now we have somebody who is ready to explain to us, answer our questions, and who is understanding our plight. So I think you really did a good job without any, much training, but you tried to see how we can, calm them down and address their concerns. Savita ji's return has taken onus of her mistake, clearly communicating, composed, trying to make amends. That I agree. So assuring of the corrective action rather than the punitive action. So rather than talking about the punitive action against anybody, if I assure them of the corrective action and the preventive action, CAPA, I think that will be a, shifting their focus to a more constructive, plan, which will bring change in the system and would reduce the number of errors. That has to be the focus of the discussion with them. So let me quickly share the presentation with you to discuss some more points, and also let you know, although in theory we talk about all these things, but what happens in reality is very, very, very different. Give me 1 second to see if I have the presentation. Okay, should be this one. So is these slides, are these slides visible? They're loading right now.
Yes, ma'am.
Okay. So a couple of slides we have already discussed. I'm not going to with these we have discussed. So I think I've discussed this also with all of you that according to JCI, medical error is the third commonest cause of death. So almost like 250,000 deaths occur in US every year as a result of medical errors. It's not a small number. It's a huge, huge number that we need to, remember. Even in India, around 5.2 million errors happen annually. I think it's an estimated number. It must be much more than this. So this is a study done by Dr. Ashish Jha from Harvard University. Okay. And most of the errors are around medication and the patient care and surgical procedures. And we have discussed this earlier also that mostly these errors are because of the poor communication between the team and with the patient. And that's how these kind of errors happen in the patient care. So it's important to understand the definition of medical error. So medical error is, what is medical error by the way? What is medical error?
Medical
There's
error.
yes, madam, please.
Yes, Dr. Tanu, go ahead. Yeah.
Medical error is an error happening during the course of treatment which leads to untoward outcomes.
Can you repeat? Can you please repeat?
Medical error is an error happening during course of treatment which leads to untoward medical outcomes.
Absolutely. But then at the same time, what we need to remember,
Diagnosis
when
also
we
is
fail
important.
to do something, or we do something that's not part of the treatment plan. Either we fail to do the right thing, or we do something that's not part of the. So for that matter, I always tell practitioners to follow standard treatment guidelines. So if somebody follows standard treatment guidelines, one is that you are well aware of what needs to be done. And then also you would not get into non-evident, practice. So we are now very vehemently, emphasizing to practice evidence-based practice. Because if there is evidence, if there's a precedence, you're safe. But if you venture into doing something that is not, documented or that's not done anywhere, and if you try doing something like this, there you are taking a risk and that can do harm to the patient. So error may lead to a harm or may not lead to a harm, but error is an error. So it's not always when it has led to any adverse outcome or patient harm. What is an unanticipated outcome? So unanticipated outcome is when the result differs significantly from what was anticipated. But patient would see that also as an error, because for them anything not within their expected outcome is an error or failure on our part. The third is about omission. That is something that should have been done, was left undone, and is neglect of a duty. So we need to have clarity on all these three things. Now let's understand the patient's and the physician's understanding of error. So for example, if I go by what is patient's definition of error? So for them, definition of error is very broad. What they think, anything and everything, even if it was a non-preventable event, For example, you did a surgery and there was, for example, for an eye surgery, vitreous leak is one of the possible complications, or nucleus drop is one of the possible complications, or detachment of retina is one of the possible complications. But if something like this, which is documented as a possible complication, is also considered as an error by the patient. Whereas for doctors, the definition of error is very narrow. That's only when you deviate from the standard treatment of care, then you say it was an error. Whereas for the patient, even poor service quality or poor communication is also taken as an error. Then what is patients' expectations of disclosure? So they would like to know all errors that cause harm, even including the near misses, where actually no harm has happened, but that according to them, they would like to know about it. Whereas we know very clearly, we would only want to disclose when we think that error has happened and it has led to some significant harm. So you may have seen a lot of time, lot of errors are covered up as part of the recovery or part of the surgery or part of the treatment. Then how to disclose an error? Patients expect it should be done truthfully and in a compassionate manner. Whereas physicians normally think that I just need to share the details in a matter-of-fact manner, in a professional manner. So they would like to do it objectively with minimal disclosure. They would not like to go into the details of saying what exactly happened or how things got, out of hand. Apology. Now, my question to you is, we all know patients would expect apology. But question is, how many of us are okay with the idea of apology? So what do you say? Well, how many of you agree with the idea of apology? Raise your hand. How many of you think that yes? Where are others? I can't see their video. Okay. So that means you agree that apology works. But my question is, how many times are we willing to apologize?
Actually, now a different situation has also arisen.
Mm-hmm.
It has been found that people actually tape the conversations when you're having conversation with them.
Absolutely.
And it gets taped, and that kind of becomes a proof of
evidence
your
evidence against you. I completely agree. Patients expect apology. And once you are giving an apology in this manner, yes, an error has happened. That can definitely, be used as an evidence against you. And that's why we hesitate giving apology. But I'll discuss with you when I talk about the protocol, what kind of apology can work in our favor. We'll talk about it in a while. But I completely understand that there are concerns to offer apology because we know it can go against us and can be used as an evidence against us. Okay. Now, next question is when to have the conversation. Patients feel it should be done immediately or as soon as possible. Whereas physicians or the treating doctors feel when I have all the facts, then I would like to tell. So again, when the patient and the family is waiting to be told, and they are not told immediately or as soon as possible, they feel that either a cover-up was being made or maybe delay in information would lead to loss of information or giving them a chance to change the information, which is taken very negatively by the patient and their family members. Now, next thing is, what do patients expect? What do you think patients expect? Write in the chat box. Write in the chat box, what do you think patients expect? Okay, compensation, honesty, clear communication, actions to be taken and communicated to them. Yes, I think that's true. What more? What do others say? I think yes, I agree. Compensation is something they would, and how far are they wrong or right? That also needs to be discussed. Then should be given priority in treatment. Yes, I think that's also one of their expectations. They want corrective action to be taken or preventive action to be taken to make sure that no harm goes. Okay, taking responsibility. Yes, I agree, Chandana. Acknowledgement how it would impact the patient. So that means they want to understand what implication it has on the patient's health or lifestyle. Then people taking responsibility of what has gone wrong and like whoever has done it. They need someone to communicate in a proper way to them. Yes, I agree, Dr. Amreen, that somebody has to, honestly come forward and talk to them and address their concerns. And then, of course, compensation. Even Savita ji says that it's, somebody asking for. Absolutely right. That means there are a lot of things that the patient or the family expects from us. And when you'll see, most of it is right. If you put yourself in their position, I think each one of us would expect something very similar to it. So one is that they want full disclosure of harmful effort. Whatever has happened, they want a truthful, honest discussion about what actually happened. So whenever we try to cover it up, they get to know. They also expect a statement from us that yes, error has happened. So even if you're trying to beat around the bush and not say this with the fear that maybe this is being recorded and it will be used against my evidence, but let me tell you, the moment you say that yes, error has happened, usually you're disarming the other party by kind of admitting that yes, but it is never one statement, it is the total behavior. When I say yes, error has happened and I'm sorry for it and I feel bad for what has happened, it is taken differently. And if I say yes, error has happened, but that's possible, it can happen in any place, even if you had gone to a best of the hospital, something like this would have definitely happened. So that means I am not genuinely kind of handling the situation in a compassionate manner. So I'm trying to kind of say it can happen. So, I mean, even if you had gone to a very big hospital, something like this could have happened. So that means you are not, empathic with them. Also, they want to understand the details of what happened. So when you explain them what exactly happened and how things went wrong, even that helps them to see. Sometimes they understand the human fallibility in an error. They're able to see memory lapses or action lapses. Then they want to also understand the implication to their health, why it happened. Of course, how will reoccurrence be prevented? So when you are able to take their attention to the point that how you are going to make sure that things do not repeat, they also feel happy that, okay, our case has been able to set up precedents for correction. Then, of course, they expect an apology. Although we say that, yes, disclosure should be done, in a study, 90% of the doctors, they said that, yes, disclosure should be done. But only 30% actually do disclosure in the proper manner. So out of 10 cases, you'll only see 3 doctors doing it in a meticulous manner. The rest all will be more or less doing a cover-up and try to, give a minimum set of information. Studies also suggest that 2/3 of the errors are not reported, especially if it has not done any harm or if it is a near miss kind of a thing. Even if disclosure is done, it never meets the patient expectation because what they expect is very different from what the doctors offer, more like a statement of facts and a matter of fact thing. Then also, trainees are often not trained to how about, how to go about disclosing. I don't know how many of you have had any training into it. Anybody? Dr. Amreen, have you had any training?
No, ma'am.
She's in gynae, she's regularly attending the patient. Whereas, I mean, there's all possibility of errors or complication or some bad news that you need to share with your patient. but there's no formal training. To the extent, even she has said that, seniors would normally, take a back seat and they will expect you all to handle the situation. So imagine no training, no support. So each one of them will do it the way they think is the right way. It may go well, it may not go well. So anybody would like to share their experience where they tried doing, disclosing the medical error and what was the overall outcome? I'm sure a lot of you must have had some experience into something like this. Anyone?
Actually, we had a case
Mm-hmm.
where a patient came in, like in her 50s, she came in for a laparoscopic cholecystectomy.
Mm-hmm.
And while she was being weaned off the anesthesia, she developed hypoxic brain damage.
Oh.
So essentially, she went into coma.
Mm.
So we had to explain to the family.
Mm.
So we did explain to the family, and we actually agreed to take care of her for the rest of her life.
Mm.
We did that. So she was with us for 6 months after that, then she passed away.
Oh.
So they accepted it because we agreed to take care, and all expenses and everything was taken care of by us.
Mm.
All her clinical care, medical care, everything was taken care of by us.
Mm.
To be honest, it probably worked because her children were living in Bombay and she was living in Haryana, and it kind of made things a lot more easier for them.
Mm.
But they accepted it. They kept coming to meet her, and they were satisfied with the care given. And so no legal action happened, but yes, there was considerable expense. So that is what we did.
Absolutely. But I'm glad that your hospital took the decision of, taking the responsibility.
So actually, mine was a charitable hospital in the sense with a very strong spiritual background.
Mm-hmm.
So it was done as this thing, and all the doctors contributed without any monetary compensation to the care. So that is.
I think that really makes a lot of sense. So you really have to go out of box to see how you can actually, help the family or compensate the family for it. But of course, the kind of loss they had or the suffering the patient had, that cannot be compensated.
That cannot be.
And in this case,
then they did not go to the court, and all that was.
Yeah. Also, I think in this case, probably it was a little elderly lady, as you're saying, that her kids were in.
Yeah. And so children had moved to Bombay, so
they could accept it. And had it been a young lady,
then it would have been like, if she had small children or something, then it wouldn't have been.
Absolutely. Then it would have been very, very difficult to manage. Yes. Thank you. Thank you for sharing that. Any other case or experience that you want to share? Anyone who has actually seen something similar to it and the family asking for compensation, and how did you manage and how did you handle it? Don't share the case by naming the hospital or the patient, but just say I know about a case. Even if it is from your own setup, I don't want you to talk about your setup as naming them. But experience sharing will definitely help us see how others are managing and how you need to. Amreen, do you have any experience to share from your?
Yes, ma'am, we had some experience that we have a camp organized at some primary health centers and CHCs regarding the tubectomy, that is laparoscopic tubectomy. And in that case, if any failure is there, then the patient comes for the compensation, or we can say for the claim, that is 30,000 rupees is given to the patient. But most of the time it happens that when they come, we do all the examination, pelvic examination, urine pregnancy test. But if she was in ovulatory stage, then the pregnancy outcome is going to happen. Whether she's pregnant or not we'll come to know next month only, not at the time of our tubectomy. So most of the time it used to happen that patient used to come after 3 or 4 months after the surgery, and they used to compensate for that. And we used to ask them regarding the history. Then we used to take out the case papers. And then we used to talk to them. If that came out to be genuine, then only they were given compensation. Otherwise, we had to counsel them that it is not the failure of the surgery. You were already having, you conceived at that time, and you hide that from us. So there is the result of that. So,
but are they convinced with that explanation?
Most of the time they used to get convinced, because it was their fault also that they hide. Because I used to ask them this also.
Yeah.
I always used to take the proper history. And I used to do my signature. So my laparoscopic surgeon used to be very happy with me, because he knew that I'll take the proper history. So somewhere I will protect him from all these certain medical errors also. So he was very happy with me.
Absolutely. That's so true. Yeah. So definitely, I think we need to be very careful when we are, working on the patient. Make sure that you follow the standard treatment guidelines. And then, of course, if something like this happens, then we have to be ready to talk about whatever has happened with the patient. So let me, anybody else who would like to share? Any other? Dr. Kunal or Dr. Anuradha, if you have anything to share. Okay. So yeah, so let me go ahead with the presentation. Give me 1 second. Yeah. So we did this role play and we have had the discussion about it. And I think it did give us some idea that it's not easy breaking bad news or disclosing medical error, because you are on the target, and then you are answerable, you are accountable. And plus, let me tell you, your conduct in that situation will decide how will the patient or the family take it further. And if you're able to manage it well, mostly you are able to control the situation. You're able to handle it. Okay. So the question is, mostly doctors feel embarrassed to talk about the error that has happened, because they fear that there can be aggressive reaction. They fear that there can be litigation. And just because of that, they would sometimes, try to not to talk to the family, which again goes against them, because that also, goes against them. And most of us, try to cover up or minimize the, amount of information that you are going to share with them. Even very seasoned doctors, they feel uncomfortable and distressing to communicate these medical errors. It's not easy. It's not easy. Now, what are the barriers to disclosure from the clinician's point of view? What do you think? What are the barriers? You can write in the chat.
And the clinicians are not good at the communication skills.
Sorry, come again.
Clinicians are not that good in communication. How to communicate with the patient in an effective way.
Absolutely. So because we have not had any formal training, whatever communication skills we have or we have learned by observing others, that's what is our baseline. But unless you have had a formal training into something like this, it requires working on yourself. It requires understanding the protocol of sharing. It requires a lot of practice to overcome your emotions and also, handle the other person's emotions and respond in a responsible manner. So again, it's not easy. It's not easy. And like somebody said, Dr. Kunal has written, okay, Dr. Arjun says, pressure from management. Yes, you are scared that you will be in trouble. Then there is a fear of aggression. Yes, Dr. Tanu, I agree. Then difficulty in accepting and taking responsibility. Absolutely. I think you fear that if I take the responsibility, one, I will be labeled as careless or irresponsible. And then also I will lose my image in the eyes of the hospital and also among the patients and society on the whole. Then admitting to medical error requires inner strength. Absolutely. It requires a lot of strength because, there are consequences of admitting and there is a fear of legal action. Absolutely. I read. So there are many, barriers to it. For example, a lot of time we are skeptical of the benefits of the disclosure and we consider it as unnecessary, especially if no harm has happened. Then we would normally say, why the hell should we tell? Where is the need to tell? Whereas it is one of the patient's rights to know. And when you don't do it and later on one of your staff member goes and speaks about it to somebody, the patient or family can again, put you in trouble. Also, we consider that why put them into unnecessary distress to patient and the family. We think that we can manage it, we will manage it, we will give the required treatment or corrective action, but why to put them into distress, because they'll be more apprehensive and worried about the impact of the outcome. Also, when we think patient is unlikely to find out, we don't want to share the information. We also fear retribution from the patient. The patient will become revengeful, may take me to court, or may become aggressive, or fight with me, or physically manhandle me. Then also you fear retribution from your colleagues and management and your peers. So you want to kind of avoid that situation. A fear of legal action and financial judgment. We all know, a lot of us have heard so many cases where the doctor or the hospital on the whole had to compensate the patient financially. And then we also know that we fear that the emotional outburst that is going to follow after you disclose the error, sometimes very, very difficult to handle. You fear actually physical violence against you. Many of us also believe that disclosure is primarily a factual conversation, and we do it in a very, very impersonal manner. And as a result, the impact of the disclosure actually brings more problems than actual resolving the conflict. Also believing that the outcome is not related to action on the part of the person disclosing. So it had to happen. It was possible. If we think like this, then we say, I'm not responsible for what has happened. And then lack of training and error disclosure. So all these things act as a barrier to the disclosure. And that is why most of us are not very comfortable going ahead with the disclosure. Now the question is, what are the benefits of disclosure? Evidence suggests that skillful conversation and follow-up can reduce the risk of litigation and violence. A study by Harvard also suggests only 3 to 5% of the patients who are injured by the negligent care actually sue. Most of them, after having a verbal argument or an expression of anger, they would normally end it there and go back with remorse, but would not go ahead with the legal action against you. The question is, why do patients sue? That's very important. For example, any idea why do patients sue? What do you think? Why do they sue?
Well, when a patient is not confident of getting any kind of what do you say, like, proper response from the hospital, where the people are in denial and they kind of shirk the responsibility or don't own up to themselves. So then the patient will think that, legal recourse is the only way for me to make them come to, so otherwise, if like in the earlier cases, the hospital itself.
I think we lost her voice. So if you remember, we discussed.
So if the hospital and the management or the doctor specifically takes responsibility and also suggests the corrective measures, then there is no need for a patient to, it's actually additional headache for the patient. One is the suffering of the problem and taking care, and then running around the court and lawyer and all these things. So it is not something a patient would want to do happily. But then, when you're left with no other option, that is when probably they will go to the court.
So if you remember, I had shared this study with all of you that in almost 70% of the cases where the patient had sued the hospital or the doctors for medical negligence, the problem was not medical negligence. It was communication failure. So whenever they are not given, effective communication, timely communication, proper information, they feel that they have not been given a fair deal. So either they want to take a revenge by pulling the hospital or the doctor to the court, or to get more information about the case. They think that, okay, legal way we can get all the information. And studies have shown that the most important factor in people's decision for the lawsuit is not negligence, but ineffective communication. Lack of empathy and feeling of being mistreated or not getting a fair treatment. That's another reason. So when we are being very professional, very, I don't want to use apathy, but then insensitive or not very, compassionate and understanding. They feel that they can sense the coldness in our behavior. And that really makes them feel bad. Also, when they feel that actual information has not been shared, or actually that has happened, or they perceive it as though this has happened, that also, motivates them to sue the hospital. And then, of course, a study by, University of Michigan, that really brought a very startling, impact of full disclosure policy that University of Michigan, implemented in 2002. So in 2001, they decided that we are going to, go ahead with full disclosure, and everybody will, follow it. So you can see the impact from August 2001 to August 2005. They noticed that the annual cost, litigation cost, went down from $3 million to $1 million. So almost like 1/3 of what it was. Also, the average time to resolve the claim and the lawsuits, which was like 20 months or 21 months, came down to 10 months. So almost like 50%. And time saved, manpower saved, all these are also indirect, savings and cost cutting. The number of the claims and lawsuits went down from 262 to 114. Almost like less than half, you can say, 40% or something. So I think this really brings us to an understanding that implementing full disclosure policy in a real sense will definitely bring down the litigation cost. And also, and in that they clearly, not that they settled every case, they evaluated every case where they saw the patient actually genuinely underwent a wrong, procedure or a wrong treatment. They compensated promptly, they addressed their concerns, and they did whatever best could be done. And anywhere they saw that this case has no ground and the person is just falsely implicating the doctor or the hospital, then they went to the court and they waited for the legal action. But most of the cases they were able to handle out of court and also settle them. So I'm going to share a couple of guidelines. Some of them are quite similar to what we talked in Breaking Bad News, but some are really very relevant. So these are based on the recommendations from the Canadian Patient Safety Institute and UK's National Patient Safety Agency. So I found this very relevant. I am not sure if India has any such policy or protocol that they are offering. So I found it very useful. So I thought I will share with you. So something like preparation in the Breaking Bad News, even for disclosing any medical error, it's very important to first of all prepare yourself. So when you say preparation, I think very important is to check in yourself, in what state of mind you are in to talk. If you are aggressive, upset, feeling low or anxious, I think it's important to make sure that you can handle it very well. You can also seek assistance from your trusted colleagues who can help you in handling the situation, who can guide you, who can tell you how to go about. I think this is one thing we really, really need to work on, because that's a support system readily available. But we normally do not, make use of it, or we do not tap it. But it can be a great source of, support for anybody who is facing a situation like this. You can also review the available medical facts to also, when it comes to explaining to the family why you did it, what you did it, what were the options available. Then it becomes more logical to explain if you have all those medical facts at your hand. Then you have to prepare yourself for strong emotions, because you're likely to experience emotional burst out by the family, because they are very upset about what has been done to the patient. And of course, internally, you're also going to feel a lot of emotions like embarrassment or humiliation or feeling low and anxious. So you really need to prepare yourself to handle those emotions. Then coming to the performance, when it coming to performing, how do you go about? I think most important is begin by stating that there has been an error. The more you will try to avoid saying this, more they will press upon you to agree that error has happened. डॉक्टर साहब गलती हुई है ना, ये बोलो पहले में, आप बताओ ये गलत, आप मुझे बाकी कुछ मत बताओ, आप मुझे पहले बताओ गलत. So what they want is, yes, a error is happening. Although we think when I say this, it's going to go against me. But when you, the follow-up discussion that you will have will decide whether the patient is going to use this evidence against you or is going to be okay with what you share with them. So most important thing is to say, yes, this thing has happened with your patient. Then describe the course of events, how it happened, why it happened. Use simple and non-technical language so that they can understand what you explain to them. In case if you try to use, technical jargons and you name some procedures and name some complication, they are not going to be, okay with this. Yeah, Dr. Savita, you want to say something?
Actually, as you are talking about all these errors and all, see, the thing is, when I'm talking from the patient's perspective, because I don't come from I don't belong to the medical fraternity, so I'm just trying to look at it. See, we kind of, doctors are the ones who treat patients, and kind of, we are putting our lives in their hands. For any situation. So it is like, it has been told so many times कि doctor भी भगवान का रूप है, I mean भगवान का दर्जा देते हैं हम उन्हें. So we assume as a patient that, nothing can go wrong by them. That is actually, I realize that we are unfairly putting them in that position. They didn't ask to be treated like gods, but we have put them. And then that burden of, behaving like God, some of them do. They assume that they are God, but then most of them are not. So it actually puts a lot of pressure of, performance on the doctors. And that could actually be a major reason why this disclosing of any of the errors, it is not that knowingly, unknowingly, whatever.
Savita, it's. I think what you're saying is right. At the same time, I would put the responsibility on the doctors of couple of things. The moment patient says, "Doctor Sahab, aap Bhagwan ho," I think it's important to tell, I'm not God. I will do my best, that I can assure you. That's one thing. Second is, if you practice informed decision making, and if you involve them in decision making, then the onus of the outcome is completely not on you. If you have been able to discuss about the possible complications or things that can go wrong, even that kind of prepares them. So usually in the beginning, when we avoid talking about it, thinking that it is unnecessary, making the patient anxious or giving unnecessary information and, creating more confusion, you may save that minute or 2 or 10 minutes. But later on, when something like this happens, plainly what they're going to say, you didn't tell us anything about it. You never talked about it. So we can't take it like this, that, oh, it happened, there's a possibility of happening. So it has to be dealt right from the beginning in a manner where they kind of are prepared for what is possible. Of course, medical errors they will not expect. But then, are we doing things responsibly? I'm reading that book by Atul Gawande on checklist. And I mean, very beautifully he explains, for any human mind to remember every procedure in an accurate manner, and these steps is absolutely beyond a human capacity. Because what we practiced 30, 40 years ago, medicine was very, very simple. Today, the procedures, the medicines, 13,000, diagnoses, 4,000 procedures. And it's just not the name that you need to remember. You need to remember the steps of doing it. So imagine. So for that, we need to have some checklist which we can follow. And if you follow the checklist, these errors can be prevented. So whatever errors the case studies that I shared with you, or the case studies that you must be seeing in your life, if somebody had followed the proper protocol, these errors could have been minimized. That's the point I'm talking about. So if you describe them what happened, if you explain to them, and if you link it what was shared with them in the beginning, they are able to understand that this is one of the possibilities. So when you're talking to them, use frequent pauses so that in case if they want to ask something or whatever you're sharing with them, they get time to, assimilate and understand what you're saying. That will help you to have a dialogue. rather than having a monologue where just you are talking and the patient party is just listening. So frequent pauses are very important and very, very helpful in such a situation. Then, of course, allow the listener to ask a question. There will be times when they want to ask, but if you are continuously talking, they will not be. You can even ask them. I'll be talking about in the next couple of slides, that let there be an opportunity to ask questions, and whether you can ask very clearly, do you have any questions? What questions do you have about it? And you need to address those questions, very promptly. Now, after you have done this, I think, and then of course you need to state the nature of mistake that happened and the consequences and corrective action that you have already taken to minimize the damage. If the patient needs blood, then you have arranged for blood. If the patient needs ICU admission, you have already moved the patient to the ICU. If the patient requires whatever corrective action, and you have already done it, that needs to be shared with them. And then, of course, after this, you need to offer apology. And as we were discussing the role of apology, I agree with your concern when you say, I'm sorry that you have been harmed, that means you are taking the responsibility. But actually, sorry has two versions. So the first version is where you say, I'm so sorry that this has happened with you. And in case if I have gone wrong, and if I say, I'm really sorry, I gave you wrong medicine, I'm truly sorry for it. The first will always be appropriate in both these situations. The second one will be appropriate only when it is true. So in case if you are actually not responsible for what, for example, if it's a complication and you need to inform. So, I mean, if you say, I'm really sorry that this happened in your case, although the possibility of something like this is just 1 in thousands. But unfortunately, in this case, we have this. So they can see that you haven't done it deliberately or it's not an error, but it has happened in their case. But in case if, for example, if I have amputated the wrong, body part, I can't say that I'm sorry this happened to you. I'll have to admit that I'm sorry I did this. And then maybe you can explain what happened and why all that happened. So sometimes the apology fails. And usually when it fails, there's a reason behind it. For example, if you say, if there was an error, I would have definitely taken the responsibility. So that means you are still not taking the responsibility. There was a mistake, but that's one of the, possibilities in a healthcare setup. But the mistake certainly did not change the outcome. Your patient has not been harmed. We just sutured, we had to put 10 sutures on his leg, but your patient is not harmed. Or sometimes things like this happen. We don't do it deliberately, but then this is part and parcel of healthcare. So when you make such statements, they're bound to bounce. They're bound to create an, animosity, and they're bound to fail. So we have to understand that we don't have to apologize in this manner. Then step 4 is take responsibility. Use I statement. Don't blame or speculate, and do not accept fault unnecessarily. Because if you do that, then you are likely to, get into a legal trouble more. Then invite questions. Ask them if they have any questions or concerns. Address them. Never leave those questions unaddressed. Make a follow-up plan by explaining next steps to minimize the damage and what CAPA for future you're planning. Discuss how to meet the needs of the patient and family. So you can't say, I can't do anything. You'll have to go to another hospital for this because we don't have a treatment facility here. And after that, you don't, answer their questions. You need to, even if you need to refer that patient to a different hospital, how that's going to happen, what's going to happen, how are you going to coordinate and cooperate and, facilitate. All that needs to be discussed in this. Then plan for the next update. So if I'm giving you an update now, when will I be coming back to you? Or whenever they need, like for example, Anuradha offered the phone number that you can, speak to me directly in case if you have any concerns. So in these cases, giving your phone number will be taken as a wonderful gesture that they can get in touch with you. And then also after that, you need to be accessible. In case if they try to call you, you don't pick call. If they try to meet you, you don't meet them. it's going to go downhill. Can aggravate this situation. I don't know if you remember that case. I think that happened in Bombay. So one of the cancer patient was operated by an oncologist, and something went wrong during this surgery. So after this surgery, this surgeon did not meet the patient and her husband, although they had a lot of respect and faith in this doctor, but somehow he just failed to meet them and talk to them and explain them. They got so frustrated with this that this doctor is not wanting to even come and meet and talk to us and explain what exactly happened. They actually sued him, and I almost like after 15-20 years the doctor was punished for whatever had happened. And it's one of the very few cases long ago it happened. So what I'm trying to say, if you're not accessible, if you don't want to talk, it could be out of fear or any other reason, but then that's going to aggravate the situation. Once they meet with you, once you are able to allow them to take their anger out, usually they become calmer, usually they become manageable. But running away from the situation will not help. Very important point is documentation. I think that's something we have to always remember, because it's very important to, first of all, report the incident and action taken by you. What exactly happened and what actions were taken, because that's something that's going to save us in the court of law. Rationale for the clinical decision, what you did and why you did, very important. Clinical outcome and plan of care, whatever happened when whatever you did as a result of that, and what do you plan to do now, all that needs to be documented. And then discussion with patient and family. What you discussed, what you explained. In that, please remember to make the mention of the name and the relationship of the person with whom you discussed. And whatever questions they asked, you answered them, explained them. All that needs to be part of the documentation. And that's really, really going to be a great help in case if you are into any legal. Last but not the least is debriefing. It's very important to sit back and self-check in. Also discuss with colleagues. Don't shy away from discussing with the colleagues to understand what more could have been done. That will really give you a lot of insight into how others are managing such situations. Reflection helps us improve. It's very important to sit and do a thorough work on it and see how others have been managing and what you did was right and what was not appropriate, so that you can improve your performance. So just to summarize the steps: preparation, that is check in and also get all the information. State what happened simply to the family, apologize, take responsibility, invite questions, make follow-up plan together with the patient and family, document, and then of course debrief. At the organizational level, I think it's very important to integrate disclosure, patient safety, and risk management activities on regular basis. By not addressing these issues, you're not minimizing the situation or reducing the possibility, but rather you are just trying to assume something like this is not going to happen to us, or we will not have to face it. It can happen to anybody and everybody. So establish a disclosure support system where the person who is, who's the one who is the target is supported. Like we talk about the second victim, I think this is a very appropriate place to where we make a mention that we need to support this person. Nobody does error deliberately. But if that's not addressed properly, the person feels isolated, and therefore people try to avoid disclosure. So provide background disclosure education, give them training, mock exercises, consider situations, possible situations. So that will give your team more confidence in how about going about dealing with it. Then ensure disclosure coaching done time to time. So one activity, one random once done is not enough. It has to be repeated number of times so that it becomes ingrained in the the way we handle it. Then provide emotional support to the healthcare professionals, because they are also experiencing a lot of emotional turmoil when they got into it. Create a culture of patient safety where we make sure that we don't make mistakes, at least not twice. Because if we have made a mistake, if we have taken an action, that mistake will not be repeated. Then also reporting the errors has to be encouraged, even if no harm has happened. I think one of the pillars of creating culture of patient safety is where reporting is always rewarded and not punished. So creating a culture of employee safety where one person is not targeted or punished or retributed, but rather it's taken as a responsibility for all of us that we have failed in this case. And we need to work on it and make things better. Creating a culture where people report errors promptly without the fear of repercussions. We have discussed this. Use performance improvement tools to track and enhance. So just training is not enough. So sometimes we really need to evaluate this exercise done by people. Give them feedback, what you did well, what was not the right way of doing it. That's how they would improve on doing this. So if you have had some familiarity through role plays, mock exercise, at least when you will be doing it in real life situation, you'll be slightly better prepared than just venturing into it without any training or exposure. So that's the idea why we insist on training and mock exercises and coaching people in disclosing the medical errors. So this is all about disclosure of medical errors. Yes, Dr. Arjun, go ahead, please.
Yes, ma'am. Ma'am, in this case where the surgery was done on a wrong patient, so there I think the hospital process is at fault more than the surgeon or individual. So the hospital, someone from the during while disclosing the error to the patient, is it a good idea to have someone from the hospital administration also there along with the doctor, so that decisions are taken fast, out of court settlement also can be done immediately, patient needs are addressed? What do you feel, ma'am?
See, if you will say that this is a process failure, in case if there's no protocol for the patient safety, then I would say yes, it's a failure on the part of management. But I think most of the hospitals are following the patient safety protocols very precisely, very accurately. Only thing is we usually fail to implement it in real sense. So for example, even if we talk about the surgical safety checklist, how many of the surgeon, anesthetist, and the nurses actually genuinely follow the checklist? That's one thing. Second, having a person from HR would help in one way, because probably they will be able to handle it in case if they are mature and they are confident to handle that situation very smartly. Yes, they can provide quick relief, but sometimes it can actually misfire. Because when we have two people talking two different languages, the patient either may get confused or may indulge into selective listening and then say, no, that fellow said that you will be compensated and now you're denying. Or your doctor was saying that we will not charge you, but you are charging me for this. So it can cause confusion unless both the people are on the same page and the order in which you are going to. So maybe if you have a prior meeting before the disclosure and you are on the same page, you can do it. But usually I think what they expect is first of all to hear from the doctor, from the treating doctor, that what has happened and why that happened and what have you done to this. So majorly it's the anger that they have. Of course, they will also bargain and they will negotiate things with us. That's also one of the possibilities. But usually it is the anger they want to get with. But if you are able to handle it in a mature manner and let them vent, also you offer apology and compassionate this thing, they would calm down usually. And even if they had the desire to ask for compensation, a lot of time they say it doesn't look good. People will think that we are trying to encash our patients' ill health or they may, get decided. Even to the legal action, if they say, and if we say, I mean, you can take legal action if you want, but how is that going to help the patient? I think more than that, let us focus on how can we improve our patients' care and, health. I mean, I would suggest you to, rather than working on, calling the police or calling media, maybe that will give you satisfaction, but that will not bring any good to the patient. I would suggest that let's together work on, making sure that the patient gets the best of the treatment and we help the patient improve. So what you're doing, you're taking their attention from taking any negative action, rather than saying, कर लो, जो करना है कर लो, आपको legal करना है कर लीजिए, आपकी मर्जी है, मैं तो कुछ नहीं कर सकता. So in a very smart way, you have to handle that argument and shift their focus to the patient's welfare. And that has to be a very genuine effort, because people are able to make out if I'm just faking and I'm not actually genuinely, concerned about their welfare. There's a program that was conducted by National Law University, Maharashtra, and that is doctor-patient conflict resolution. So that program was done by the law faculty, and excellent program. It was, I think, 3 or 5 days program. I went all the way from Delhi, lived there for 4 or 5 days and attended that program. There was a lot of learning. Because
in Bangalore, ma?
It happened in Bombay, National Law University, Maharashtra, I think, Bombay. Excellent program. I think, I don't know, like after that, how many, they had doctors who have done law. There were lawyers who have dealt with similar cases. There were speakers who were doctors, but they have good knowledge about how to handle conflicts and how to really negotiate. And I think that's very important. Going to the court is no solution, but finding a midway where the family feels that they have received a fair treatment and you also minimize the damage for your hospital is something that we all need to learn. So I was seriously considering, doing that program. That was a workshop that I attended, that there's a course available in all the courts, like in Delhi also, I inquired. Initially, it was only for the lawyers, but then they have now opened it to people from different fraternities who have good 10, 12, 15 years of experience in their subject and who want to be, it's a mediation program. The name of the program is mediation program. Again, that's, I think, 3 to 5 days program, a very rigorous program. They teach you the techniques of mediation and how do you resolve conflicts and settle cases out of the court. So I think that's another thing that we can consider in case if you want to seriously learn how to handle such cases. Because eventually in these cases, usually money is involved, compensation is expected. So if I know the right ways of doing it and giving a fair chance to both the parties, even like, for example, if you speak to the patient and explain them, see, this has happened. One is I go to the court and fight the case in the court for 10 years and get compensated, or if I can find some way to help my patient recover and do something good and also, get some financial compensation so that I don't feel that I have been cheated. And similarly, when you explain to the hospital management, the ultimate cost they will have to pay by showing them a couple of examples where this has happened and showing them that this is a better option. So, mediators really can do a good job for both the hospitals and for the patients. So one should consider doing it. I think more and more people should get into that. Any other question or any comment or feedback? No question? Okay, then I think I'll share the feedback form, and Dr. Arjun, Navnita and Chandana, please, 3 of you, share your PPT with me and you need to speak to me so that we can, discuss and finalize your content. And please don't do it on the last day, because sometimes even I am occupied. So do it, much in advance. I think this is the first experience I'm having where my participants haven't, done it in a very meticulous manner. Otherwise, I think all 2 batches really did a wonderful job. And we really came up with good learning also with that. It's okay. It's all right. We all, make mistake in life. But I mean, it dilutes the seriousness of the program. That's my concern, which I don't want to go for. So please share your PPTs with me. Fix time to talk to me. I can do it in the evening for you. It will be morning for me. Around, even if you say 9 or 10 o'clock in the evening, for me it will be like 12:30 during the day, which is comfortable. I can speak to 3 of you one by one. You refine your PPTs and then make the presentation next week. Okay.
Yes.
Meanwhile, let me share the feedback form with all of you.
I have a question to ask.
Yes, ma'am, please go ahead.
Sometimes what happens is that you have talked to the family, they are sorted, and then more and more people keep coming in, the relatives and all, and they keep on, adding questions like, or they want a repeat meeting, and then the things become ugly after a while when things have been sorted out. Well, how does one handle those situations?
So one is you have to be really very smart at handling it. A lot of time, people who may not have any genuine, relationship with the patient, but they have a lot of nuisance value.
Yes.
So I talked about social triaging. That's a term I have coined. I mean, anytime in history when this will be talked as social triaging in healthcare, it has to be, because we talk about medical triaging, but we need to learn social triaging. So in case if it's just a matter of 5-10 minutes of talking to this person and explaining and calming that person, it's worth an investment. Don't make it an ego issue and say, I've talked to so many of you. How many people do you want me to talk to? That's one thing. Second is, I always say, please know the primary caretaker. It will be mostly the son, daughter, wife, husband, or the immediate family member. To that person, you can talk directly after you have finished talking to this person and tell them, see, I understand your relative's concern. I completely understand that they are all hurt and they're very unhappy. But if every time they come to me and if I have to explain it again and again to them, it's actually affecting me also. More than this, I will prefer, concentrating on the care of your patient so that we can, help the patient recover faster and do best to the patient. Can you manage and talk to them and explain them? In case if you have any question, you can talk to me. But then I think it wouldn't be possible for me to handle everybody, every time they come to. And I know they are genuinely concerned. I understand their intention. But for me, humanly, it's not possible to do 2 things at a time. And as it is, even I feel bad for what has happened. So you have asked the primary caretaker to handle them. But in case if somebody has come asking you, do not, avoid or snub or just say, see, I can't talk to so many people. I've already talked to the patient's son. I mean, I don't know who you are and why the hell should I talk to you? That's going to, he will make sure that you are punished for your poor treatment. So welcome, Dr. Preeta. We are about to close.
I'm at a wedding.
I know.
At a close friend's family, and I now everybody sitting. I said, no, I want to go and meet everybody because today is I'm so sorry,
No,
but very close friend's daughter.
Luckily, it's not the last day. It's not the last day. We are meeting once again next Tuesday.
Oh, great, great,
Yeah.
great. That's great.
Yeah. So couple of things. I will be requesting all of you to give your feedback about the program for a minute or so in the recording. That's all. Not very long feedback. So whatever you feel or think about the program. So if you can jot down a couple of points, you have now 1 week time to think and jot down. So I'll be recording that. That's one thing. Second, I have already announced batch 5 from 27th April. I would request all of you to give at least 2 names whom you think you would like to recommend this course. If you could just share their name, contact number, and email. I will not be bothering them. I'll be just sending them one email with the message that your name has been shared with me by so and so. And in case if you're interested, I can share with you details. That's all. I will not be doing like bombarding them with the messages. And I normally, as a last line, I say, if you don't want to be reminded, please say, do not disturb, and I will not send you any further messages. And I then delete their number and from my contact list, because that's not fair to bother them. But those who say that, yes, I would like to be informed, only to them I send the message. So I've shared the feedback form. I think, let's see how many of you have already answered. Okay, 6 of you have already done. Even the, okay, so please make sure that all of you have done the completed the feedback form. And then let's meet in the next session.
Okay. So, ma'am, we are meeting next Tuesday, right?
Next Tuesday, 8 o'clock is okay?
Great. Yeah, ma'am, fine.
Most likely it will be like 1 hour session, that's all. Because 3 people who were to present today, we haven't had any discussion about their presentation.
Okay.
So I wasn't sure that how will their presentation go. So we decided that I will discuss with them and then they will make the presentation. So do we end it here?
Yes.
Thank you so much, everyone. Bye-bye.
Okay, ma'am. Thank you. Bye-bye, everybody.